information. We want to thank Fred for his lifelong work in trying to help the veteran community. So post-traumatic stress, we're trying to get rid of the D as a disorder. Nobody wants to be labeled as having a disorder. It has a really bad connotation, so let's change that D to disability or depression. How about we just drop it altogether? Let's just call it post-traumatic stress. You could be in a bad car accident and have post-traumatic stress. You could be in a fire and have post-traumatic stress. There should be no stigma of being in a situation that leads to stress and where you feel you need help. Fred mentioned that 30% of the Vietnam veterans, when they came back, probably had post-traumatic stress. It's estimated that 24% of our current military service men and women have post-traumatic stress. That's 1 in 4. So that's really the topic that we need to focus on. Because that post-traumatic stress and that moral injury, which Fred mentioned, going against their moral compass, that is leading to the suicides. And we have to change the stigma, have the conversation, offer the services, and as a community, think of it differently. You know, as a community, that's why you're here. As a community, we need to understand, to be knowledgeable and to think differently. There's nothing wrong with them. They just had a traumatic experience. There's nothing, they do not have a disorder. A disorder kind of lends to that they're never going to be cured. No, they're going through a crisis and we need to be there. So our next speaker is a man that knows all about this. It is Dr. Harold Cudler, and he came a long way to be here today. So Dr. Cudler received his MD from Downstate Medical Center, trained in psychiatry at Yale, impressive, and associate consulting professor at Duke, and an adjunct professor of the Uniformed Services University of Health Services. From 2000 through 2005, he co-chaired the U.S. Department of Veterans Affairs, the VA, Special Committee on Post-Traumatic Stress Disorder, I'm going to change that, which reports directly to the Congress. So here's a man that's been deeply embedded in the VA system dealing with post-traumatic stress. He has served on the International Society for Traumatic Stress Studies Board of Directors, co-led development of joint VA Department of Defense guidelines for the management of post-traumatic stress, and advised Sesame Street's Talk, Listen, Connect series for military families. So yes, families are impacted at all levels. From 2004 to 2014, he was the Associate Director of the VA's Mid-Atlantic Mental Illness Research, Education, and Clinical Center on Deployment Mental Health. From 2006 to 2014, he co-led the North Carolina Governor's Focus on Returning Military Members and Their Families. Yes, he traveled all the way from North Carolina. In July 2014, he joined VA Central Office in Washington, D.C. as Chief Consultant for Mental Health Services. Starting in May 2017, he served as the Acting Assistant Deputy Undersecretary for Patients Care Services until his retirement from the VA in June of 2018. You thought you could just retire? No? No, not possible. I thought I could retire too, not possible. A Distinguished Life Fellow of the American Psychiatric Association, Dr. Cudler plays a leadership role in a number of mental health organizations, including the International Center for Multi-Generational Legacies of Trauma. Dr. Cudler is the current president of the Psychoanalysis Center of the Carolinas and chair of the Service Members and Veterans Initiative of the American Psychoanalytic Association and Military and Veterans Committee of the Group for the Advancement of Psychiatry. Let's give a warm welcome to Dr. Harold Cudler.
To speak, that hopefully my talk might be shorter than that introduction, but we'll find out. It's a pleasure to be with you here today, and one reason why it was important for me to come up here from North Carolina, which really isn't that far, is because I care so much about this kind of community gathering, and that's the theme of what I'm talking about justify being here is take the important action. So my talk is called Building Communities of Care in Support of Service Members, Veterans, and their families, Connecting the Dots. And we can go to the next slide. There we go. Ready? Yeah, let's go to the next slide. That's great, thank you. Always nice when someone else changes your slides for you. So, the key point is to understand and promote the well-being of service members, veterans, and their families. You'll see it abbreviated as SMVF. You work in government long enough, you do a lot of acronyms, and you know that from the military. For their sake, and the sake of our nation, we have to consider factors which extend beyond the traditional limits of healthcare to span communities and culture. And the military is a culture, I think, as most of you know very well. Back in 2005, I co-chaired with a military person the first DoD-VA conference on deployment mental health. And when I went into that meeting, after months of planning for that meeting, kind of like what Rosemary did for this meeting, I thought, oh, we're just going to create this giant map of all the treatment programs in the nation and out, across the ocean where our military is, and we're just going to figure out who's got the problem. We're going to send them there. Job done. By the third day of that conference, I realized this is never going to be solved in a clinic. I mean, I've been a VA psychiatrist I spent 30 years working with combat veterans, World War II, Korea, ex-prisoners of war, Vietnam, about half the guys were from Vietnam then. One woman in those days. Now they're 15% of our workload. The fact is, cannot be reduced to a medical issue. And I think Mr. Miller's getting at that when he says, let's not make this a mental disorder. This isn't about mental disorder. These are problems in living. And they're complicated, and you need a community to deal with them. It is a public health problem. And the problem is that most doctors like myself were never trained in public health. We don't think at that level. We see the patient in front of us, not the bigger issue. So communities of care. I would define those as complex systems that work across individual, family, and community domains to promote the well-being of service members, veterans, and their families. We're often, there are tensions between clinical models. For instance, diagnosing and treating post-traumatic stress or post-traumatic stress disorder or depression, and public health models, which consider the social determinants of health. And the social determinants of health, do you have a roof over your head? Is it stable housing? Do you have enough food? Are your kids doing okay? These things actually predict more of the variance in your health outcome than do the medicines you take, the diagnoses you carry. So we have to change our view of what medicine is and what care is. And communities can do this in a way that doctors can't. Next slide. And an historical precedent. This is a picture of Thomas Salmon, who volunteered in World War I to be the Army's first chief consultant in psychiatry. And he went with the Army to Europe and followed across till the end of the war. When he came back, he, along with the American Legion, were the leading advocates for the creation of the VA system because there was no place for veterans from World War I to come back. There were some post-Civil War military programs for veterans, but they were really old soldiers' homes. They weren't hospitals. And these fellows were ending up on roadsides and in prisons and not getting the help they needed. Let's go to the next slide. So shell shock was mentioned by Mr. Miller, and the Europeans, remember, Europe was in World War I from 1914 to 1918. We got in 1917. So we had a lot of opportunities to study what European doctors were doing. And Salmon went before the American troops went to England to study the British. And he saw that European military doctors were treating shell shock strictly in a clinical lens. Soldiers remained in the trenches until they had enough symptoms to merit a diagnosis, and then they became patients. They went to hospitals, sometimes near the front, but usually in the rear, and then often, because most were British, they went back to England. But they didn't get better. And in fact, they ended up filling up all the available hospital beds so that people in the community couldn't get into psychiatric treatment. Not that there were a lot of psychiatric beds in England at that time. So consequently, the fighting force was significantly diminished, and the hospitals in the rear and back home were completely Next slide. So here's Salmon in the Army in 1917. He developed a public health approach. He said, look, rather than get zillions of doctors, which we don't have anyway, let's train all American troops to recognize early signs of stress in their buddies. You know, you're sitting in the trench, you're playing poker. Who's not playing poker anymore? Who's staring off into space? Who can't hold their weapon without shaking? And then let's know how to help. You know, you don't have to be a doctor yourself. Which way do you point? Who's going to help with this? Rather than demote war fighters to the rank of patients, Salmon insisted that when people began to develop the early signs of stress, they be kept in uniform, put on light duty, loading and unloading trucks, helping out in lots of ways. They're still soldiers, they're still able, they're still needed. But he insisted also they get rest, nutrition, and reassurance that soon be back to the front. The hardest thing, even now when we have combat stress control teams, is taking people off the line because military members don't want to be taken off the line because who will have their buddies back? It's very hard to convince them, give us 3 days and we'll get you back there, and you know that'll be better. Next slide. So Salmon's strategy actually aligned with military culture, which views the health of the individual as inseparable from the health of the fighting force. After 3 days of what is often still called 3 hots and a cot, the vast majority of these soldiers, sailors, Marines, airmen, coasties, returned to full duty and performed well. Medical treatments of their day, or even treatments of today's medicine, couldn't match these results. If you just said, well, I'm a doctor, I'm going to help you, you couldn't get there like this. And in fact, in Iraq and Afghanistan, our combat stress control program, 97% return to duty rate, which is amazing. I don't know a psychiatric treatment. There are many medical treatments that work 97% of the time. Go to the next slide. And the core lesson from this is that shell shock was, as Mr. Miller said, a valid clinical diagnosis. It's well worth treating. So is post-traumatic stress disorder. And post-traumatic stress disorder is a problem for you, and it can be for many people. Major depression, substance use, traumatic brain injury, these are all real things. And I'm not saying don't do everything we know in medicine that might help for that. But a purely medical approach is insufficient. It's not enough by itself. Military-related mental health problems require a broader approach, which is culturally competent and addresses basic requirements for well-being. And I think Mr. Romaine was speaking to this. Yes, any licensed doctor can treat you for depression, although most of them don't, unfortunately. But will they ask you about your military service? When you go to your doctor, do they ever ask you, did you ever serve in the military? It's unlikely they did. And one reason they don't, I'll tell you as a doctor, they don't want to ask a question they don't know the answer to. There was actually a study done by RAND in New York State, sponsored by New York State, that showed only 2% of all the licensed health providers in New York State have the military cultural competence and clinical competence to treat these problems related to service. So what do we do? Well, I want to point out in the next slide, April is also the month of military child. We've got a couple days left to focus on that. So I want to say a word about working with military veteran children and their families, of whom there are 2 million currently. And many of you may be military children. 57% of everybody who serves in the Army are the children of veterans. The resilience and the vulnerabilities of military parents help determine the resilience, lifelong resilience, and vulnerabilities of their children. Children are often the most sensitive barometers of family well-being, and yet these children aren't identified as military children in the schools they go to. So if they're in the guidance counselor, maybe they have no idea that they may be living with a parent who's dealing with visible or invisible injuries brought home from the war. This isn't to say, and I want to be absolutely clear, that being a veteran is bad for your children. Absolutely not. It's actually quite inspiring for your children. But, and it helps them in many ways, but there can be issues and it's good to know about them. These principles apply long after separation from the military to influence the health and well-being of family members for the rest of their lives and, in fact, across generations. Next slide. And a word about the Guard and Reserve. They usually live far from military bases, treatment facilities, or child care providers. and they may feel like strangers to military life. Their families don't often think of themselves as military families, although in these last wars in Iraq and Afghanistan, these people deployed often as much as their active duty colleagues and with less training and less equipment. So this is very important today and very important here on Long Island. They're also less likely if you're in the Guard and Reserve to have steady support from other unit members, spouses, partners, or children, or reliable access to family programs. So these are issues Guard and Reserve members are a little more isolated, and they need some special attention. And next slide. So let's talk about the domains of communities of care, because sitting here in this room, you are a community of care, and have the potential to strengthen that, to become a network so finely woven that nobody can fall through it. Communities of care improve access to information and support through concerted action across multiple domains. This requires innovative policy, practice, and partnerships. And the VA cannot do this alone, because the VA does great work within its hospitals and its homeless systems and its suicide prevention programs, but clearly not every veteran, in fact, most veterans do not use VA care. So what do we do with the veterans? And in fact, veterans dying by suicide, 60% of them haven't been to a VA for at least for mental health service for the last 2 years. So how do we reach them? Well, they're your neighbors. Policy, practice, partnerships. DoD and VA programs are often necessary, but not sufficient to meet these needs. It literally takes a village. And next slide. These principles were recently endorsed by the National Academies of Science, Engineering, and Medicine in a 2023 report entitled Achieving Whole Health. And Whole Health is a national program that the VA is piloting and building out. Say a word about Whole Health. Let's go to the next slide. The National Academy Committee defined whole health this way: physical, behavioral, spiritual, and socioeconomic well-being as defined by individuals, families, and communities. The important thing about whole health, when you go to the doctor, when I go to my doctor, she goes out of her way to tell me what's the matter with me, and it annoys me. You got this wrong and that wrong, I don't even want to hear it anymore. But whole health starts with what matters to you. You sit down with a health coach, talk about how your health's doing, how your family's doing, how your life's going, and you talk about, well, what do I want to accomplish? What's important to me? What makes me me, and where do I want to go in this life? And are these things getting in the way? And then they help you plan, using VA and community resources, how you're going to address those things the way you want it, what matters to you. Because quite frankly, I can tell people lose weight. My doctor tells me to lose weight. I haven't done a great job. But if I do things in my life, they might be more powerful in many ways. To achieve these things, whole health care is interprofessional, team-based, anchored in trusted longitudinal relationships, not just medical relationships, but includes them, to promote resilience, prevent disease, and restore health. It aligns with a person's life, mission, aspiration, and purpose. And next slide. And this is delivered through primary care, integrated care. Mr. Romaine pointed to this. In the VA, every primary care clinic has embedded mental health staff. That doesn't usually happen anywhere else. But the other groups could be doing this. And frankly, one thing, all of you have doctors, I hope, that you see once in a while, hopefully not for problems. If you ever ask your doctor, I just came here, I served in the military, my spouse served in the military, my child serves in the military. You never asked me about any of that. Could you start asking people about that? And if you don't know much about it, here are some websites. One of my goals for retirement, which I have never done yet, is to write a book that in the back it'll have all the websites, and there'll be a tear-out thing that you can bring to your doctor and say, read this, but I haven't gotten there yet. I'll get there. Next slide. And here's a local example that I started working with, 5 years ago, 6 years ago. They got a table over there, Operation Initiative Foundation, and really through the outreach of Lou Falco, who was the first president and founder of that. Founded in 2013, Operation Initiative Foundation is a 501c3 nonprofit based here on Long Island, which provides a broad range of support for service members and their families as they transition to maintenance status, which is a crucial part of the arc of a military career. I can tell you that really tough, smart military doctors I know who have served overseas and done all kinds of stuff that I don't think I could stand up to. When they talk about leaving the military, there is fear in their eyes. They don't know how to do that. And if that's somebody who has means and background and has a job they can fall back on, what about the average person coming out of the military? How do they make that turn? It's a very big one, and doing it right means everything. So it's a critical opportunity to engage and improve their trajectory going forward. Next slide. This is the 2023 Operation Initiative Foundation 14th edition of its resource manual. If you thumb through it, it's organized by what you need, as opposed to what, all the nice things they'd like to say to you. It's, what do you need? You can look it up here, you can find it. Here's the phone number, here's the websites, the information, how to do it. Mention dialing 988. Every state created its own 988 system. Federal government said the whole country's going to 988. You call it up for anything mental health. But every state was left to figure out, how do I populate my 988 directory? If you dial 988 in New York State, I don't know how many of the resources that are in this manual you can go to. So you say, I'm a veteran with a housing problem in Suffolk County. Are the housing alternatives for Suffolk County in that? Not necessarily. I worked in North Carolina to make sure that they were there in North Carolina, but I don't know if they're there in New York or South Dakota or a lot of other places. States' rights are a great thing, but a federal agency is nice too. Yeah. So, these are the services that you really need in addition to good doctors, which are always a nice thing. Housing, nutrition, education, employment, financial. A lot of people are undereducated or underemployed, even though they have benefits that could help them with both. Family and social support. The VA is not great on families. Veterans themselves often said no veteran's going to stand in line behind even a family member at a VA medical center. But you can't do the job without engaging families. It's not possible. And frankly, advocating as family members at your VA is not a bad thing to do. You can even say, I said so. I don't work for them anymore. And spiritual, as again, Mr. Miller was speaking to as a chaplain. Spiritual makes a world of difference. People are 5 times more likely to talk to a congregational leader or a lay leader than they are to a doctor about these kind of problems. So if the congregational person doesn't know where to go with that, it's not going to be helpful. Now, one thing that Operation Initiative speaks to are a lot of alternative treatments. Now, I'm trained, I'm supposed to be a scientist, I like to think, but doctors are really applied scientists. We're not, laboratory scientists, usually, some of them are. But there are a lot of things here that are now considered complementary and integrative treatments. We don't have great clinical evidence yet for all of them, and we don't know why they work. But when I was in medical school in Brooklyn, we didn't know why aspirin worked. We didn't stop prescribing it. And I can tell you that every one of these things has helped someone that I couldn't help with traditional medicine. When I say traditional, I mean the things I learned in medical school and have learned since. So Operation Initiative can connect people with acupuncture, hyperbaric oxygen therapy, evening. Maxine's here, maybe speak to her, she's at the table about that. Massage and meditation therapies, nutritional guidance and support, Reiki, and yoga. Are these things helpful? All I can say is, in 30 years of meeting with veterans in my clinic, sometimes when a guy finds yoga, changes his life. I think that's great. I wasn't trained to prescribe yoga, but I mention it frequently. All right. Operation Initiative, one thing I like about it as a model, I'm not just plugging them, there are many good organizations here today. So go to all the tables by all means. But what I like about Operation Initiative, one reason I keep coming back to work with Lou on this is it's replicable, community by community through Rotary clubs. You need a driver. It's not enough to get up and give a speech, and then go fly back home and say, well, job done. You need a driver who's in the community of the community. And Rotary clubs exist across the region, across the state, across the nation, and internationally. Rotary clubs could be driving this in every community. welcome all the doctors in their community. Have you asked your patients today if they or someone close to them to serve in the military? It began as an initiative of the Rotary Club of Glen Cove, but they've already grown with regional impact across Long Island and well beyond. And they create, and if you go to the next slide, they create a way of moving this system across the country if people will begin to pick up on it. Sesame Street, I've trained thousands, I've worked with thousands of veterans, I've trained thousands of health professionals. I've never touched as many lives as I did through Sesame Street. Things like this are huge interventions. And what was really cool about it, I went to Camp Lejeune one, but it was supposed to say Camp Lejeune, but everybody says Camp Lejeune, so you're stuck with it. And they were doing a live show USO put on, based on our Sesame Street production. Talkless to Connect, there are newer ones out there now, if you go to their website. But Marines were actually standing in line for hours to go to a program to talk about these things. They would never have gone to a hospital to talk about these things. And these were active duty Marines who had been deployed over and over again, the 2nd Marine Expeditionary Force. Medicine wasn't going to get these people in the door. Sesame Street did. There are lots of ways of reaching people. So key takeaways on this next slide. There can be no single approach, not just medical and not just community. Peer support is an amazing thing. I didn't trust it when I met my first peer support people at the clinic. Well, what are these guys going to say to my patients? They're going to mess up the work I'm doing? No, peer support is wonderful. Peer support keeps people from walking out of the waiting room, let alone keeping them involved in their program and helping them and being available to them in ways that I can. There can be no single approach. Always look for synergy across multiple programs. All these tables here, get all their material, bring it home, put it in your own Rolodex.